I'm one of roughly 30 cleft surgeons in the UK and work at North Thames Network, which is basically Great Ormond Street Hospital, and Broomfield Hospital St Andrews, which is in Chelmsford in Essex. As I said, sadly I won't be talking to you about cleft surgery, but Alex has asked me to spend a bit of time chatting to you about the syndromes associated with clefts, the symptoms and signs of clefts that are referred to the service, sometimes days, months and even years after their birth. The cleft types, we're talking more specifically about isolated cleft palate. As was mentioned by Alex, 40% of children born with a cleft have just that involving of the cleft itself, of the palate, which may be just the hard or soft or combination of both. And unlike the cleft lip, advances even in 3D ultrasound, we still cannot reliably diagnose the cleft palate antenatally. So we really are relying on that early newborn examination to diagnose an isolated cleft palate visually with the tongue depressor and the torch. As I said, the cleft palates can be complete or incomplete. I, as a surgeon, tend to operate, and most of the surgeons in the UK, between roughly 8 and 12 months of age. And I'm very reliant upon the whole team, to optimise this child for a most effective operation. So the earlier the referral is, the better generally the outcome of the actual surgery, and therefore the speech, and therefore their development. As you've seen in some of the cleft slides already, there are many shapes and sizes, and we'll go in more detail later on this evening. And unfortunately, the children born with an isolated cleft palate tend to be our sickest kids, with a high proportion of comorbidities, cardiac, respiratory, endocrine problems, especially if you work at GOS. Hence, the role of the cleft MDT and the early referral is really important. Obviously, a dedicated cleft paediatrician is crucial in advising the whole team of when it's safe to operate and when the child is actually optimised for that operation. And as you may already know, there has been documented 400 syndromes. So in the 5 minutes I've got tonight, we're going to talk about a couple of them, I think, associated with cleft palate, isolated cleft palate. So we're very grateful to have paediatricians, dedicated paediatricians on the team to help us with those. These are the early signs and symptoms, and as a routine, if you were to inspect the palate at birth, you would see the cleft, but unfortunately, we're being referred children all ages. The very early days and weeks after birth, perhaps our cleft CNS may get calls from various places, health visitors say the child has poor feeding, some nasal regurgitation, as you've seen on the video. Mum can't breastfeed, the parents are very anxious. The trust element is obviously massive at this stage. Later weeks and months of age, the child obviously then may go on to failure to thrive. Again, the family or friend may have spotted something that was different than one of their previous children. And again, it's this trust issue. We're engaging with the families for the next 20, 30 years. So it's really important we gain the trust of the family right away at the beginning. Very early on, we may not see the problems associated with syndromes, the cardiac or respiratory issues, but as the months and weeks go by, they may present with actual medical conditions that are related to having an isolated cleft palate. Through our speech and language therapists and audiologists, as the child gets to years of age, and it's not uncommon to see 3 and 4-year-olds that have a significant cleft of the soft palate present with ear infections, and that's the first time they ever saw a clinician in a cleft team. And through our speech and language therapists, through a palate investigation clinic. So that's the sort of symptoms and signs, as you probably heard the mum say on the video, of an isolated palate that may not have actually been seen at birth. I won't be talking to you about the 400 syndromes, but these are more of the common syndromes that you probably know a little bit about already. They may be associated with a chromosomal problem. A lot of people may have come across 22q11 deletion. It's had lots of different names: Catch-22, DeJoy syndrome, velocardiofacial syndrome. basically, these are very, very challenging children, and some of the outcomes of these particular children are not predictable. So the sooner we know about these children, the better for the best outcomes. I'll talk a little bit more in detail about Paediatrics. As you can see in this slide, there's lots of associated with inheritance. Stickler syndrome, an autosomal dominant condition associated with connective tissues. These children are prone to retinal detachment because of significant short-sighted. So an interdisciplinary or multidisciplinary team approach to the care of these children is really crucial, so we get to know them very early on as possible. Craniofacial colleagues we work very closely with in terms of looking after children with certain craniofacial syndromes, Treacher Collins, hemifacial microsomia. You may have come across Van de Woude children. This is probably one of the commonest causes of cleft lip and palate due to a single gene. And this is associated with lip pits, which is very obvious on the lower lip. And to name just a few, looking specifically at Paediatrics sequence, thankfully this is quite an historical slide really. I think I borrowed from Julie, and we work really closely with our respiratory team. All teams do. This child obviously is very near to respiratory collapse. If the child was to survive, there would be feeding difficulties and failure to thrive, and obviously later communication issues. And as you can see from this child born with a small jaw, basically it's not a syndrome, but it's a sequence of events really. The child, due to the small jaw, the palatal shelves have been unable to actually join. Probably a simplistic way of explaining it, but the tongue is held very high within the palate, so they get a very characteristic U-shaped cleft palate. Thankfully, these children do come to see us. These children are struggling virtually from the beginning with their feeding and their problems with their breathing. And these are some of the signs and symptoms you would get with a child with a characteristic micronathia, glossoptosis, or a tongue that is likely to obstruct the airway. Nasal flaring, tracheal tug, lip recession, cyanosis, grunting, neck extension are all things that thankfully we don't see a lot of because we're actively managing these patients with nasopharyngeal airways and NG tube feeding through the whole MDT. And luckily, these children do get to see us fairly early on. Some of the characteristic faces that we see from the syndromic point of view, as I said at the beginning, these are our most challenging patients. And we wouldn't know about them basically at the very beginning, but the sooner we get to know these children within the actual service, the better really. 22q11 deletion syndrome, these children, their palates basically may not have a significant cleft, may just be a soft cleft palate, but functionally the muscles are hypertonic. They may not even, when you do the repair, there may be an adynamic nature to the actual cleft itself. Stickler syndrome, working with our ophthalmic colleagues, we really need to get to know these children really early on because the chances of a retinal detachment is very high. So just to finish, the importance of coming to or referring to the service very early on is highlighted in some of this data basically. It's data from 2001, but it's still completely accurate to date really. 30% of all our patients have medical problems that are unrelated to the cleft. 40% of those are syndromic, and they tend to have multi-system issues really. Of the non-syndromic, 22% still need treatment and ongoing follow-up. And of all those syndromic patients, virtually all of them require some form of treatment from the multidisciplinary teams involved and further follow-up. So it's an early message, but the quicker we can diagnose these children, the better. Thanks for your attention. I'll pass on to the next speaker.